you are what you eat is
Right.
very much the case. And there's certainly benefits to exercise, and I think the folks that did the Duke study emphasize that exercise is important for health and has a lot of healthy benefits. But when it comes to weight and a lot of the chronic diseases that come along with excess weight, clearly diet is the big driver.
And you know, I have to say that we have to give the devil his due here. The reason that we are talking about food and the way food is tied to health outcomes in that context, that's largely because of the Make America Healthy Again movement, and we have to acknowledge that RFK is really spearheading that.
I agree. We're seeing these, the Wall Street Journal articles on United Healthcare and what they were doing with risk adjustment. The government should feel a lot more comfortable in just taking plans off the rolls and not including them if they're not going to be doing it, not just finding them.
Hello and welcome to Debunked, where we discuss healthcare news with a little bit of personality and pizzazz. Samir has left unexpectedly for a European vacation with his family and his mother and brother, and has left me high and dry. I thought I would have to fly solo this episode, but at the very last minute, a knight in shining armor has appeared to help this middle-aged woman damsel in distress, I should say. So I am so pleased to welcome Paul Markovich. He was CEO of BlueShield of California until very recently, and now leads the parent company, the nonprofit parent company called Ascendiun. Welcome, Paul. I'm so glad to have you on this episode.
Well, thank you so much for having me. I don't think you've really ever been a damsel in distress, but I'm happy to be here and jump in as your co-host.
Perfect. So let's get right to it. Normally, Texas is not a place I look at in terms of taking the lead on health issues, but this interesting story out of the Lone Star State really surprised me, actually. So Governor Greg Abbott signed this sweeping bill into law, basically that is requiring food companies now to put a warning on their product if it contains any of 44 additives, which is commonly found in like baking products, candy, and drinks. Now, you know, I firmly believe that there's a strong link between our food intake and our health outcomes, especially if you look at chronic diseases. I was just in Italy, so I will give you the example of Italy and the US. In Italy, according to their Italian Institute of Statistics, they looked at the data and saw that 20.9% of people in Italy live with 2 or more chronic conditions, and 40% live with 1. If you compare that with the US, in the US, 6 out of 10 people, that's 60%, live with chronic chronic diseases, one of them, and 40%, 4 out of 10, deal with 2 or more. So, you know, I understand there's diet and exercise, I get all of that, but I do really feel that we are at this moment in time where we need to hold food companies accountable, and I feel like we are probably seeing more than that we've ever seen before. What's your take on that?
Yeah, well, yeah, it's interesting the timing, because there was just a study released last week by Duke researchers where they estimated the caloric output of populations across the world. They used this method of doubly labeled water, which tracks really closely how many calories you expend during the course of a day. And they did it with populations, you know, across the world, not just in developed countries. And what they found was that despite the fact that people in developed countries were more sedentary, the actual caloric expenditures were very similar, just adjusting for the size of the person, very similar everywhere in the world. And their conclusion was that the biggest driver of obesity and the rise in obesity worldwide was diet. And they also found in a sub-analysis that there was a high correlation between the consumption of ultra-processed foods, which I think this bill was trying to get at, what you were talking about with the food additives, and obesity. And so, you know, I think it's you are what you eat is very much the case. And there's certainly benefits to exercise, and I think the folks that did the Duke study emphasize that exercise is important for health and has a lot of healthy benefits. But when it comes to weight and a lot of the chronic diseases that come along with excess weight, clearly diet is the big driver.
And you know, I have to say that we have to give the devil his due here. I mean, RFK Jr., there are a lot of things that are problematic. You know, how he has dealt with the whole vaccine situations in terms of, you know, this year the measles outbreak has been particularly bad, right? I think it's the worst in 3 decades. And of course, I'm going to lay some of the blame in the at the feet of RFK Jr. because of his skepticism on vaccines. And of course, there's issues on, you know, stories right now that he wants to fire all 16 members of the U.S. Preventive Services Task Force. So all of that is problematic. But I think the reason that we are talking about food and the way food is tied to health outcomes in that context, that's largely because of the Make America Healthy Again movement. And we have to acknowledge that RFK is really spearheading that.
I agreed. Yeah.
Okay, moving on from that, and since I have you here, on July 22nd, the House Ways and Means Committee had a joint oversight and health subcommittee meeting on Medicare Advantage and the fraud and waste and abuse that go along there. For those that don't know, Medicare Advantage, of course, is, you know, private health plans paid for by the government. Highly popular, especially because it tends to address gaps in traditional Medicare when it comes to, you know, screening and preventive services, as well as, you know, vision and dental coverage. But the problem that has been occurring, one problem, is that because these are privately administered, even though the government is actually the final payer, they are deciding, the insurance companies are deciding which claims to pay. And sometimes we've reported on this, there are delays, there are denials, there's rampant fraud too. And so providers, many of them are not happy with inadequate reimbursement rates, and they are dropping, you know, MA contracts. So this hearing, you know, brought 7 different witnesses, and 2 of them were from insurance companies. One was the CEO of Alignment Health Plan, Don Maroney. That's a for-profit plan. Then there was Sachin Jain, who is CEO of SCAN, exactly, SCAN Health Plan. And I think what I thought was really interesting is that, you know, there were people that were conspicuous by their absence, like the large for-profit, you know, health insurance companies, the United Healthcare, Cignas, Humana, and CVS's of the world, and many of them have actually, you know, either under investigation or paid fines to settle. I think it was, I forget which one it was. I think Cigna paid a $172 million settlement because they were falsely upcoding, you know, diagnosis. So they get paid more, but their expenditure was much lower because people were not sick in the way that they were claiming to be. They, meaning the insurance companies, were claiming in terms of getting paid by the government. So a settlement had happened. So I guess my question to you is, should for-profit health plans be in the business of selling Medicaid plans? Medicare Advantage plans.
Yeah, I wouldn't draw the line about who sells and administers Medicare Advantage plans based on a for-profit status. Okay. But I would draw the line based on performance and how they're behaving. Okay. And so if it turns out that there's that kind of friction being introduced to the system, those kind of challenges with the customer. I mean, we're seeing these, the Wall Street Journal articles on United Healthcare and what they were doing with risk adjustment. Right. Would be an example that of behavior, if true, and it certainly was compelling, what I read. I mean, that's just the kind of thing that you wouldn't want your Medicare Advantage plans to be doing as a part of serving, because it's just all it's doing is increasing revenue to the company. Effectively, what was happening in these articles was that they were sending physicians, amongst other things, sending physicians into the home, doing home visits, and they were finding diagnoses or reporting diagnoses codes for things that would increase risk adjustment scores, but there's no treatment being given for those. That's also false claims, I would imagine. Well, that's they're under investigation for it. I'm not familiar with the details. I'm just familiar with what I read in the Wall Street Journal article, so I can't tell you what's, you know, I'm on the side of the Wall Street Journal, yeah, I have to say. The analysis looked like it was very well done, so I don't have any reason to doubt it, but I'm also not, I wouldn't want to pretend that I'm somehow have insider information on this. But my point is, it's not really about whether a plan is for-profit or not for-profit. It's about what are you doing to be a good steward of federal government money in support of delivering. You've got a huge responsibility to deliver on behalf of Medicare beneficiaries, and are you taking that responsibility seriously? Are we delivering on it? And I think that the government should feel a lot more comfortable in just taking plans off the rolls and not including them if they're not going to be doing it. Not just finding them, but to really take the next step, kind of getting to a death penalty status if there's at least if there's repeated occurrences or really serious ones.
And this is what I think was important in one of the testimony. I didn't obviously listen to all 3-4 hours of testimony. I read some of the summaries, and Don Maroney said that this system should be transparent and there should be adequate enforcement. So 170 million, 150 million, 300 million, 400 million, it doesn't matter to a company with, I don't know, $3+ billion in profits, right? So what is the appropriate enforcement? I do agree with you that if they are repeat offenders, and they have done, this is not the first time these companies have been fraudulent, right? And I have to go back to what AOC said, not that I agree with many things that she has to say, but she said that whenever we talk about fraud, waste, and abuse, it's almost always the government is abusing taxpayer money. But this is a clear example of corporate fraud of taxpayer money. So again, all of this is alleged. I'm not saying that they are guilty, but as you said, the Wall Street Journal made a compelling case. So I think enforcement is really important. But other than that, the other point I thought Sachin made that was very key is this idea of multi-year enrollment. Like every year, if you don't know who your member is going to be, you're not going to want to invest in better benefits for your members because you don't know if this person is going to come back to you or go to your competitor. And again, the government is paying for these people. So maybe multi-year enrollment is not a bad idea. And I think it's not just for Medicare Advantage. I mean, Sachin was saying in his testimony that this is one of the reasons value-based care has not, moved forward, or he said it has failed, because no one has a sense of, is this person with me over the long term? This is not something that Europeans have to worry about.
Well, there's pros and cons to that approach, because on the one hand, sure, it would be helpful to know if a member's going to be with you for a longer period of time. On the other hand, I would hope that you just earn that right by treating them well. And then the other flip side of it is, we were just talking about, well, if there's plans that aren't performing very well or they're putting friction in the system, what if I lock myself in now for 3 years? It's a bit like that cellular plan that I can't get off as a member. And if that plan isn't going to get removed but have other disciplinary action, fines and other things, then you may have signed up for a plan that is just not really meeting your needs or serving you very well, and you have no recourse for multiple years. That also feels a little bit off. So I think there's probably a way to get to what Sachin's talking about, which is to try to create a system in which all the players serving the members are motivated to really think not just about the short term, but about the long term. But at the same time, you wouldn't want to be limiting consumer choice, especially in an environment where maybe there are some players out there that aren't performing as well as they should.
I'm going to push back on this a little bit, Paul, because healthcare is so freaking complicated. I don't think consumers even fully understand the choices that are available. And in terms of Medicare Advantage, you have seniors who may not understand the system well, dealing with agents, in some cases paid for by the insurance companies, right? The insurance companies pay agents and brokers. So I don't know that I fully buy into the idea of consumer choice. I think what the average human being, seniors or not, want when they buy health insurance is that I will be taken care of if there's an emergency and I will get good care. And I don't think, and I'll get to this in a minute, but I don't think even someone who's relatively healthy as I am feel that in terms of health insurance. The experience is rarely good in terms of healthcare.
Well, here's what I'd say is, I think the way the system's structured today, it's so complex that consumer choice is really challenging. But this is where I'd say you can shift things by saying, well, what if we did what California's done with the exchanges and set a standard benefit? So if you set a standard benefit or a set of benefits that are choices, then the choices are discrete.
Right.
There's a small number. They're known. They're identical from plan to plan. And so as a plan, you have to distinguish yourself on your quality, on your service, on your costs.
Makes sense.
And it simplifies the consumer choice. And it also then gets away from what Sachin was talking about is, do I invest in these benefits or not in these benefits? Well, if the benefit's set, then you just have to go out there and try to perform. And win the consumer over. So
yeah.
My point wasn't that I think consumer choice is the be-all, end-all, especially in an environment when it's so complex as it is today. I mean, there's like over 20 plans in Los Angeles County, and they all have different benefits.
Exactly.
Benefits available to them. I mean, it's an almost impossible choice. But you could simplify that choice, and you could structure it in a way where I think you set the right incentives and allow consumers to make choices I think they can make.
Yeah. I mean, I really like the Israeli system where it's not single payer, but there's universal health care, and there are 4 insurance plans competing for your, for the right to cover you. I really like that. We have so many plans, so many different things. To me, it's just unnecessarily convoluted. Healthcare should be something that is there for peace of mind. It shouldn't be that if you're sick and you're not doing well, you have to also deal with financial issues. And that's the system we have created for ourselves here. And I'm on this, rant because I just came back from Italy, where unexpectedly I had to go to the ER with my son. We were out, touring the Sistine Chapel and St. Peter's Basilica, and it was a very hot day, mid-90s and everything.
Yeah.
He probably didn't have enough water, whatever. He comes back home, showers, whatever. Evening, he tells me he's seeing through his right hand. Then he tells me a little bit later he can't feel part of his face. And
oh my God.
And I'm like, oh, Ishan, you think too much. Go to sleep. Take a little bit of rest, and you're going to be fine. And then I'm like, it just doesn't sit well with me. So I started, looking at heat stroke symptoms. Heat stroke symptoms didn't fully match. Then I had a brother who passed away from cancer, and I thought, could this be a stroke? I was like, oh my God, and the stroke symptoms actually matched. So I was like, we need to do something. I told my husband, and luckily my husband's cousin's husband, this was a family vacation with 25 people. So he was like, we'll drive you to the local hospital. This was the cousin's husband. And so we went in there. And the care there and the speed of care there was phenomenal. There was CT done, there was blood work done. Ultimately, long story short, what happened was that the neurologist felt that everything's fine. He might have his first migraine attack. So we'll see if it's migraine. We have an appointment with a neurologist here in the US, but we entered the hospital at 7 p.m. We left at 1:30 a.m. with the hospital discharge paperwork, with his blood work results, with the CD of his CT scan. Now, I know that we have amazing doctors in the US, but this is not the experience that I would have faced, even in the US. Forget a foreigner in a different, foreigner coming to the US and having an emergency. They'd be there the entire night, not to mention that the care would not be free. For me, it was completely free, and I didn't even know Italy had a nationalized health system. But because our ERs are completely overwhelmed by most likely uninsured complex patients, that if a regular patient like my son shows up, they would be there for, I don't know, 10, 12, 13 hours without much to show for. So I don't know. You tell me. I've gone long.
Look, I've come to the conclusion that our system is just irretrievably flawed.
Yeah.
And I think there's a lot of really good things that various players in the systems do, payers, hospitals, physicians, pharmaceutical companies, but there's also behavior that they engage in, and largely because that's the way the system is structured, that leads to a bad patient experience, not necessarily the best quality or outcomes. And we see it. We have this huge productivity problem in the healthcare system in the US, in that we just keep pouring more and more money into the system at a higher rate than we pour almost anything else in the economy. It keeps growing as a percentage of the economy. But quality scores nationally and customer satisfaction nationally aren't budging, they aren't moving. So we keep pouring more resources into something that's just not getting better in these types of day-to-day experiences. So it requires systemic change, and I'm excited about trying to help make that happen, but it's a heavy lift.
It is because the incentives are not aligned. I mean, the providers, if the provider is a payer like Kaiser
Right.
Permanente and Intermountain and some other groups, you may have a better experience as a patient. But other than that, I mean, the relationship between providers and payers right now are at rock bottom.
Yeah.
Everyone's pointing fingers. But I see in the press releases I get from the various lobby groups, the pharmaceutical companies are pointing fingers at the PBM companies. PBMs are saying, no, we're not at fault for high drug prices. It's the pharma companies because they do this and they do that, and it's just the end result is whatever fighting for the piece of the pie that is going on, the people are suffering because they have to deal with high prices, and it just, I don't know, it's not great.
No, it's time. Well, look, it's time for us to change and part of the changing of the system is changing the incentives. We simply won't get to where we need to get to unless we start, for example, paying hospitals to keep people out of the hospital, as opposed to figuring out how to keep them in and then code at a certain level.
Right.
Or get them to do hospital-based services and code at a certain level. So, but the fact that they do that is because the system and the payment models are set up that way.
Yes.
If we paid them differently, they'd be behaving differently.
And you were talking about site neutral sort of.
Not just site neutral. I just think, like, for example, we would like to move to more of a budget-based. It's running a hospital is largely a fixed cost endeavor. I mean, it's the biggest part of managing a hospital. So pay on a per member basis to take care of the population, and the more population that you can take care of, the bigger footprint of people you can take care of, with whatever hospital beds and other resources that you have, then the more money that you make, which means you want to figure out how to keep people out of the hospital. You want to manage that resource in a way that's different. You want to think about the emergency room and managing the emergency room differently than you do today. And so, to me, there's just it's this system, this method of payment, as at the root of it. The electronic digital system, like, we still use fax machines.
Oh,
we just went through and on prior author, we went through and did a survey recently on how the communication for California between physicians and hospitals and plans, and 78% of the time it's faxes and phone calls.
Right.
Like, we're not getting into the digital age, and of course members can't access their records without trying to put together their own spreadsheets. So it's a system that needs a lot of change.
Okay. All right. Well, I wanted to talk to you a little bit about, and this is the last thing we'll talk about, is what you, as a healthcare executive and a veteran of this industry for so long, what are you looking at? Is there anything out there that you're sort of excited about? Something that you're keeping an eye on?
Well, I'm particularly excited about a proposed California bill, Senate Bill 41, which would delink the ability of pharmacy benefit managers to tie their price to the list price of a drug.
Okay.
And there was just a study that got released on Friday, or an article in Health Affairs, where they estimated that nearly $100 billion of cost could be taken out of the system if we de-linked the ability to tie prices for those in the distribution system, pharmacies, pharmacy benefit managers, wholesalers, from the list price. And there's really no reason for them. Their administrative costs and what they do to get drugs from point A to point B and get them to a member have nothing to do with the price of the drug.
Absolutely.
It's not as if Amazon charges you for the cost of the contents of the box that goes to your doorstep. And they shouldn't be either. And if you pull those things apart, this is one of the ways, like, how people get paid. The study indicated that list prices for drugs have been going up 12% a year, but the net price the manufacturer gets is going up 3% a year.
Okay.
And that spread, that increase, that cost is something that the system bears, and it just all goes to the intermediaries who aren't necessarily adding value proportional to that. So anyway, this bill could potentially change the incentive structure in pharmacy distribution, I think, much to the benefit of Californians, and potentially create a blueprint for the whole country.
I think that's really interesting. I don't know if you knew this or not, but Arkansas became the first state in the nation by making a law saying that if you're a
Yeah.
pharmacy, if you're a PBM, you cannot own a pharmacy, and obviously promptly
Yeah.
CVS Health and Cigna has sued them. So we'll see where it goes. But I think different states are looking at different ways to rein in that relationship between PBMs and pharmacies.
The horizontal consolidation where you've got big three with well over 80% market share.
Absolutely.
And then their purchasing of the vertical integration, like owning specialty pharmacy. It's just there's so many opportunities and so much cost going into just driving up the profits of that collection of companies, but not necessarily improving care, not necessarily something that's better for the patient, and certainly not helping with affordability.
Perfect. Well, on that note, thank you so much, Paul, for stepping in. It really means a lot to me. Thank you all for watching. Please write to us at debunked@medcitynews.com. If you like something, if you hate something, please reach out to us.